How does this look for everyone?
That looks good.
Yep, that's great. Great.
Did we have some other, is Aisha or Dr. Desalu going to be here? Did they respond?
Yeah,
I'd like,
yeah. They will attend the meeting. They told me they will attend the meeting.
So should we wait another couple of minutes, Zudi2?
Yeah, maybe. Yeah. Yeah.
Okay. Can everyone see my? Yep.
Yes.
Thank you. Whenever you're ready, ZD2.
Okay, I'm ready. Can you show me the next? Okay. To start with a brief medical history, this is a 28-year-old female gravida for para-3 women presented with irregular vaginal bleeding of 4 months duration. So upon arrival to our hospital, they did a series of serum beta HCG determination, and it was ranged from 819 to 1,520. And they also did an MRI scan, and the MRI suggested AV malformation. With the follow-up of about 2 weeks, because the bleeding was persistent and relatively profuse, and they suspected for her to have gestational trophoblastic neoplasm, and they decided to do a hysterectomy. Next slide, please. So they sent us a hysterectomy specimen, which was partly opened up. So upon cut section, there was a slightly dilated endometrial cavity with a dark brown friable material, identified partly adherent to the posterior half of the fundus, which measures 3 by 3 by 2.5 centimeter, with adjacent thinned out uterine wall, but there was no gross perforation. Next slide, please. So the microscopic image, one of the microscopic image was this one. As you can see it here, there are some nests, kind of nodular aggregates of cells from low power, which some of them appears to be adherent to the superficial part of the endometrium and the myometrium. Next slide. We have also, again, similar nodular aggregates of cells, nests of cells with some areas of hyalinization. Again, most of them are adherent to the superficial part of the myometrium, but it looks at areas to extend to the outer 1/3 or 1/2 of the myometrium. Next slide. So this is a relatively high power, as you can see here. These nests of cells have relatively abundant cytoplasm. They are polygonal polyhedral cells with clear to slightly eosinophilic or amphophilic cytoplasm, with areas of hyalinization, and they appear adherent to the adjacent myometrium and with a bit of also infiltration. And it looks like there are also scattered multinucleated cells as well. Next slide. So at higher power, as you can see here, these polygonal cells with clear to eosinophilic cytoplasm arranged in nested pattern, some scattered multinucleated giant cells. But in other slides also, we couldn't find single mitotic activity and no significant atypia except having scattered multinucleated giant cells. The cells appears relatively, I could say, not significant variation among the cells. Next slide. So another areas with similar kinds of these nodules or nested cells with adjacent areas of kind of hemorrhage hyalinization, no clear-cut necrosis, and no mitotic figure at higher power. Next slide. just the high power with similar pictures in the previous slides to show the cellular detail and some scattered multinucleated giant cells. Next slide. So we have also this area. I'm not sure whether this is a kind of vascular invasion or a tangential cut, which we find it's a bit deeper to the myometrium. Next slide. We have also these areas of probably a bit deeper infiltration or probably also a tangential cut. We have only these areas. The other areas mostly confined to the upper 1/3 of the endomyometrium. Next slide. So this is just to show some areas of hemorrhage, hemostatic ladder, macrophage, and so on, to indicate that the lesion stayed a bit longer, since she has also 4 months history of persistent irregular vaginal bleeding. Next slide. So just to show some areas of hyalinization and some single cell infiltration into the adjacent myometrium with these cells. Next slide. So with this, we considered different differential diagnosis. Let me start with the least likely, and I will go to the most likely diagnosis. Least likely diagnosis are placental site trophoblastic tumor and epithelioid trophoblastic tumors. The placental site trophoblastic tumors are commonly characterized by confluent sheets of trophoblastic cells with wider area of infiltration, I mean deeper areas of infiltration into the myometrium. This tumor tends to be larger in size, but the mitotic activity is not also that much significant. But since we didn't have these confluent sheets of trophoblastic cells, they are mostly characterized by implantation type intermediate trophoblasts. But in our case, we don't have these confluent sheets of trophoblastic cells, which are deeply infiltrated into the myometrium. So we consider this diagnosis as relatively less likely. And if you have access to immunohistochemistry, HLA-G immunohistochemistry can highlight the growth pattern and help us to differentiate it from exaggerated placental site reaction. So the other differential diagnosis was epithelioid trophoblastic tumor, again characterized by a relatively larger, more necrotic tumor with nodular expansile mass, with areas of necrosis, increased mitotic activity, with Ki67 proliferation index tends to be relatively higher. If IHC is performed, P63 will be strongly positive. That helps to differentiate from the placental site trophoblastic tumor and exaggerated placental site reaction. Next slide. So the other relatively benign non-neoplastic kind of differential diagnosis for this case is placental site nodule. And this lesion tends to be relatively smaller in size. They can be multiple, but they tend to be well circumscribed and smaller in size, less than 5 millimeter, with areas of with central areas of hyalinization. IHC can be performed, and HLA-G and Ki67 dual immunostains and P63 can help, because P63 can be positive in this case, but the Ki67 index, which is very low, can help to differentiate from the epithelioid trophoblastic tumor. So the final and the most likely diagnosis we consider in this case is exaggerated placental site reaction, which is again characterized by infiltration of the endomyometrium, relatively the superficial 1/3 of the myometrium, with implantation type intermediate trophoblastic cells. But this tumor commonly, I mean, mostly doesn't have areas of necrosis. Mitotic activity is almost zero, which is again can be proved by Ki67 proliferation index, which is almost close to zero. So immunohistochemistry can also help to differentiate from the most closer differential, that is placental site trophoblastic tumor. So next slide, please. So considering this differential, our case, we received hysterectomy specimen and we found a dark brown partly adherent tissue in the uterine cavity with largest diameter of 3 centimeter. And upon microscopic evaluation, most of the cells are mononuclear trophoblastic cells, mainly confined to the superficial part of the endomyometrium with areas of hyalinization. A small suspicious areas of invasion into the myometrium, also some kind of only a small focus of kind of vascular suspicious areas of vascular invasion, but we couldn't find mitotic activity, no significant atypia or necrosis. So we also tried to do Ki67 and it was almost zero. So with this, we consider the above feature to be consistent with exaggerated placental site reaction. Next slide. So beta HCG was determined after the hysterectomy after I think 1 week. It was 70, but later after 2 weeks or something like that, it becomes undetectable and the patient discharged with follow-up after 3 months. So they didn't, the clinicians, they didn't do any additional treatment for this patient. Next slide. So I already mentioned that we have done a Ki67, which was zero. I hope the immunostain works properly and we couldn't find any Ki67 proliferation in this case. But we, since we don't have access to the other immunohistochemistry, we didn't do other immunohistochemistry stains. So next slide. So I think we can discuss on what is your comment on this diagnosis. Is the diagnosis right? And if is the management right? Do you have any other suggestion or any different opinion on this case? And if you have any additional comments. So I will give it back to you for the discussion. Thank you.
Could you go back to the history, or I guess, Abby, could we go back to the history slide, please? It was like the second slide, yeah. So I actually have a question before we start discussing this. The first question that I have is, what is the, when was her most recent pregnancy that we know of?
So the problem was that she came from the rural area. So she doesn't know whether she was pregnant or not. She doesn't have any history of curettage or abortion done recently. She just presented with irregular vaginal bleeding. That's all. So there was no previous recent curettage. And the previous pregnancies were, I think, years back.
Okay. I guess, Dr. Okekwe, did you get to see the pictures? Hello? Can't tell. Okay. Should I go ahead and comment, Lewis, or do you want to? Oh, Dr. Okekwe, I think I heard you. Please. Yes, no?
I can't hear him.
Yeah, I can't hear you. Dr. Kekwe, if you want to put your comments in the chat, if that would also, that's also reasonable, if you could, because we can't
Can
hear
you
you.
hear me now?
Yes.
Yes, yes.
Okay, so I said I'm sorry, I had some technical hitches. I didn't get to see the early slides, so I'm seeing the slides now.
Okay, so Abby, could we go through the slides fairly quickly? So this is a 28-year-old patient who had sort of HCG, who presented with abnormal uterine bleeding. HCG was in the thousands, low 1,000 and something. She underwent a hysterectomy, and this is the proliferation. The only immunostain that was done was a Ki-67, and it was extremely low. So do you want to take a stab at it? I know we're pushing, you're looking at it very quickly, but I would suggest that you might actually have more experience than any one of us in this disease type. Right?
Not really.
No? Trophoblastic disease?
Not really.
Not really. Okay. Do you want to take a stab at
Okay,
it, or do you
okay.
just want... Go ahead then.
Okay, the pictures are gone. I don't know whether this is it molar pregnancy we are looking at?
So I actually so I think that the diagnosis that was made was of exaggerated placental site reaction. So could you stop here for a minute, Abby? And is there a way that I can use a pointer or something more? Or point. Oh, here we go. Yeah. Okay, I'm gonna try. No. Annotate. There we go. So this here to me looks like a villus. And there's trophoblastic proliferation occurring off of this villus. And possibly there might be some, I'm not entirely sure, but I think, could you go to the next slide, please, Abby? Keep going. Keep going. Keep going. Keep going. Keep going.
The slides are not changing.
I'm sorry, your slides are not changing?
Yeah.
Oh.
Okay, they're moving now.
I don't seem to be able to get rid of the annotations. No, go backwards, please, Abby. Sorry. Yeah, could you go to that one and the one after that?
This one?
Okay, yeah, that one. So let me see, can I annotate? Where is my annotation? Save as eraser. So let's just erase this guy. Okay, so what I see here is that this proliferation is coming off of villus tissue. So there's at least one villus there.
Sorry, Dr.
Yes.
These are not, I think this is the picture quality. We tried to look for the presence of chorionic villi in the actual microscopic examination, and we couldn't find a single one. Probably
No, but I saw what looked like a chorionic villi.
These are the picture quality.
Okay, so
At the center, is that not a chorionic villi?
Dr. Zuditu
At the center, I'm looking like something that looks like a villus.
We couldn't
That's
find any. Yeah, no chorionic villi.
Is that not
so.
that's around there?
Yeah, so I also thought that I could see villi. So I thought that that was a villus, the one that I had drawn a circle in, but
Yeah, it looks like, but it's not. Yeah.
but so basically it doesn't matter very much whether there are villi
Yeah.
or not, in my opinion. So to me, there is a suggestion of an underlying villus proliferation. You got these nodules of cells, which is not, which suggests that even if we can't see villi, it is coming off of villus structures. You wouldn't get this arrangement with a pure trophoblastic lesion. So what I think is that this was a villus trophoblastic lesion, but the patient aborted. And so what you're seeing is the left behind implantation side of that villus trophoblastic lesion. So that could be either, an adherent abortion or an adherent molar tissue. The fact that her HCG is low and that there is no atypia or mitotic activity in this trophoblastic tissue, I think that this is, an adherent abortion, which is not very different from the exaggerated placental site, because that's also the basal attachment of trophoblastic tissue. I think it's just a semantic label type of thing, but so we're in agreement in the sense that it's probably derived from a abnormal pregnancy, probably a genetically abnormal pregnancy. And what we're seeing is the residual implantation site that was not, eliminated as she aborted. So it's adherent here. I'm glad you did the Ki-67, because I would have worried about whether this might be neoplastic, but with such a low Ki-67, low HCG, no atypia, I don't think that this is neoplastic. So I don't know, Dr. Hassel, Dr. Okekwe, your thoughts?
Yeah, I think you've picked it out as the right differential, and I think these lesions are tough because we don't see this status in the normal setting, so we don't know kind of what's normal sometimes in terms of sequelae postpartum or post abortion. Very often, my experience with placental site trophoblastic tumors is pretty limited to Dr. Young's consult files from way back, and I seem to recall those lesions being much more myometrial focused rather than out in the lumen here. So I would agree that this is not a placental site trophoblastic tumor. The Ki-67 goes along with that. I have occasionally made the diagnosis of exaggerated placental site, and it does tend to have a lot of fibrinoid changes in the uterine wall. Along with occasional villi. I don't think this looks at all like an invasive mole or anything like that. If we have time, I have a case I could show of that disorder, and maybe, I don't know, maybe Vanita would want to share the case that was recently circulated on the listserv about that as well. So I think you're right that in terms of management, there's no adverse sequelae down the road for this patient. And she should be just fine. And we can call it pretty much in that case, whatever benign, low risk lesion we want, and we'll be in good shape. But from an interest standpoint, I do think that the architecture here does suggest that there is a little bit of villus-like structure. There seems to be in some of the, papillary fragments, there seems to be an outer, almost cytotrophoblastic type of cell along with these more proliferative cells. So I think there may be a two component here, which I think goes along with the idea that there was some sort of underlying villus proliferation. So very interesting case. Thank you, Zudito.
So Zidute, I have a question. I think that in this country, they might have offered the patient methotrexate or even a curettage before they went to a hysterectomy. So was there a clinical reason that they were concerned and went directly to a hysterectomy, or do you know?
That was also our question. Probably because of the MRI finding, and probably they thought of an invasive molar pregnancy.
Do
and
you
she had like a profuse bleeding, I think.
Okay.
That's the reason.
Hello.
Yes.
Hello.
Yes, Dr. Cakeway, go ahead.
Okay. I think I have a better picture of the case that is being presented. I think this woman may have had a retained product of conception. Some of these women that are from the rural areas, some of them, they don't actually take record of their menstrual cycle, or maybe she may have aborted and she may just think it's her normal menses. So I think I can see some chronic villi, and I can see some degree of inflammation, ground inflammation.
Mm-hmm.
I think she could have had an incomplete abortion.
Yeah.
And, with some endometritis in the background. I don't think there's any proliferative lesion in the background in what we're looking at. So I think my own suggestion, my own suspicion, my own thoughts is that she may have had an incomplete abortion who retained the product of conception, as shown by the presence of few chronic villi. The chronic villi that we are seeing are not looking atypical. They are not proliferating. And there's a lot of inflammation, fibrosis. I think it's a post-abortal endometritis in the background. That's what I think she has. Thank you. That's my opinion.
No, and I think we're all essentially using slightly different labels for the same thing. So just to remind you that the old name for exaggerated placental site reaction was syncytial metritis. Right. So there was a component of inflammation, and it is the implantation site of a gestation that didn't make it, basically. So I think we're actually in agreement on this one. So I'm actually I would love to see if Dr. Cakeway, do you have a slide that you can share?
I don't have one now.
Oh, okay. So would you be willing to please maybe take a couple of pictures of what you're talking about? Because my sense is that you have greater experience and expertise in this area. So I would certainly love to learn from you in that respect. And I am going to take Lewis up on his offer because I think you might be able to help us. Maybe you can advise us on a slightly different case that is being circulated amongst gynecological pathologists. Let's see if I can bring it up right now. Okay, so Abby, am I able to share? Yeah, here we go. Okay, so this is a 40-year-old woman who presented with a beta HCG of 875,000. The DNC was a molar gestation. And this is the resection specimen. So you can see there's molar gestation, seems to be invading into the villi. It might even be protruding out of vascular spaces. So you can see there's villi with trophoblastic hyperplasia. You know, so the question is about this exuberant proliferation here. You can still see the villi, but there's a lot of trophoblastic proliferation. And then the Ki-67 is obviously very high, but again, it's just the extent of trophoblastic proliferation. So my question to you, both of you, is, in your setting, how much trophoblastic proliferation do you allow in a complete molar gestation? Do you see this type, because we are used to, most of our specimens that we get are early gestational tissues. So there is never this much trophoblastic hyperplasia, but I'm assuming that in your setting, you see slightly later presentations of the disease, and I assume, see more trophoblastic hyperplasia. So clearly this has a villus here in one corner, there's another one there. Would you consider calling this a choriocarcinoma?
Well, in our setting,
yeah,
in our setting, most of times the molar pregnancies we see they come in form of curetins, and we see lots of villi. Even from the gross, one can make a diagnosis. In complete mole, you see entirely only vesicles. In partial mole, you can see some, other tissues that may resemble part of gestational material. We see a lot of villi. And then in making our diagnosis, we actually look at the structure of the villi that we see. If the villi are large, very distended, hydropic, and then we don't see any normal chronic villi, we think of more of a complete mole. But if we see normal chronic villi with some atypical large, not as large as those of the complete mole, we consider partial mole. So our patients come in late stages. Patients that come as choriocarcinoma, most times you may not even be able to see anything. It's just hemorrhagic. So our patients present very late. They are not as the ones that you're showing us, where we have seen few. Hello?
Yeah, yes, we can hear you. Please
where
go
we're
on.
seeing few chronic villi to make a diagnosis from. Ours will have lots of chronic villi to make diagnosis for both partial and complete mole. But that of choriocarcinoma will hardly make a tissue diagnosis. Most times you have just hemorrhagic. Everything is hemorrhagic. You hardly see the features. Thank you.
But do you see invasive moles?
Yes, we see invasive mole, but most times what we see are mostly partial and complete moles.
Okay.
Other variants are not as common as the complete and partial moles that we see.
So this is an area I think is sometimes challenging because descriptively, it's said that some choriocarcinomas can have a molar element or villus elements. This was a case that we had not too long ago where there was a history of a prior molar pregnancy about 6 to 9 months before this. And then she developed recurrent elevated HCGs and came to hysterectomy. And, we have a lot of this kind of trophoblastic proliferation with atypia and so forth that you can see here, a lot of syncytial trophoblast, but obviously also clearly molar elements in the deep myometrial tissue. So, my inclination was to call this an invasive mole, even though in many areas, like say here, and down here a little deeper, you have predominantly, choriocarcinoma-like syncytial trophoblast, cytotrophoblast, with only rare little foci of villi. But in most all of the areas, there was some villus component. So I think it's somewhat of an academic distinction between invasive mole and choriocarcinoma, but the distinction can drive us crazy, even though maybe clinically they would be managed in the same way.
So I completely agree with Dr. Hassel. So the pictures that I showed you is a case that is being circulated amongst gynecological pathologists here. And the discussion is whether you can call focal choriocarcinoma arising in a molar gestation. And I think conceptually, certainly that must happen, because we know that 50% of choriocarcinomas arise in a complete mole. But I am in agreement with you. We haven't defined the cutoffs. And so it seems to me that if we call these things focal choreo in a complete mole, we are now going to be at risk of overcalling molar gestations with trophoblastic hyperplasia, just because we're not familiar with the amount of trophoblastic hyperplasia that can be seen. And in fact, I was going to write that in an email. I have the email written, which I was going to send shortly after this, because...
Well, I remember distinctly, I actually spent a little bit of time with Shirley Driscoll, looking for these, looking at these kind of cases.
Yeah.
And, we used to grade these in 1 to 10 or something like that in terms of trophoblastic proliferation. And we don't do that anymore.
Right.
And that's because, hey, everything just gets treated with methotrexate and it goes away. And if that's still the case, if the treatment is so effective that it's not going to make a difference whether you call it choriocarcinoma or invasive mole or something else, well, let's just try to call it, severe gestational trophoblastic disease and not fret ourselves about making a sharp distinction between one or the other, even though we know biologically there is some sense of progression.
Right. And I think that I completely agree with you there, because I'm also old enough that, there was a time where we were trying to grade the extent of trophoblastic hyperplasia. But the cases we see today are very different from the cases we saw 30 years ago. I mean, now you're seeing very early complete mole, which has barely any trophoblastic hyperplasia. You're basing the diagnosis on the architecture of the villi, the bulbous villi, the karyorhexis. So to me, it seems, I think it's interesting that so if you read sort of most of the guidelines, for instance, AJCC, basically they specifically state that, if you're on the border between a higher and lower grade lesion, err on the side of calling it a lower grade lesion, because we now live in a world where the sequelae of overtreatment are much more severe than potential undertreatment. And modalities exist so that the small percentage of people who do recur can be treated. So you don't want to treat 100 people because one person might have a negative outcome. So it's interesting to me that in this domain, we're looking to define some microscopic choriocarcinoma, which just seems contrary to our thought process in other areas. Like I'm sure you've seen now, we've gotten so many articles that low-grade prostate, grade 1 prostate carcinoma should not be called carcinoma. I just saw a paper that low-grade DCIS should not be called carcinoma. So it seems to me that, as we start stratifying these lesions, absent some compelling data that these patients are behaving poorly, I'm disinclined to label them as choriocarcinoma, absent. Like, we at least have to agree on the diagnostic criteria, and we don't. So,
Great point. Great point. And I think that's important learning is that we always have to balance, our effort, our costs, as well as our diagnosis with kind of what's capable, what the treatment options are going to be, as well as the biology, but really making it patient-focused diagnosis in terms of what's going to be best in their overall interest.
right. I don't know. We seem to have, I don't know, is it just me or is it everybody? We seem to have lost
We lost Suditu.
Zuditu. She was saying that they were having power outages, so maybe that's what happened.
So Dr. Akikwe, do you have any other comments? Oh, here comes Zudito back.
Oh, okay. Good.
Yeah. There's my pointer here.
Hello, I wanted to ask, can you hear me?
Yes.
Okay. I wanted to know in your climb, how are you able to make a distinction between an invasive mole and a choriocarcinoma? Do you have to, see signs of metastasis to make the diagnosis? I'm just being curious.
So for us, the diagnosis of invasive mole requires the identification of villi. And so once there are villi, you're hard pressed to call something a choriocarcinoma unless you can really find a very well-defined invasive trophoblastic nodule. I don't know, Dr. Hassel, what do you think?
Yeah, no, that's my criteria is you see a villa structure and associated with this tissue in the myometrium, and you call it an invasive mole. Particularly, I mean, you do that in the setting where, in this case, we had a prior history of molar pregnancy. If you didn't have that and you had this tissue and it was invasive, I think you still probably would call it the same thing, an invasive mole, because you've got villi and the trophoblastic proliferation. And I think that's an easier to apply criteria than to say, well, if you have severe atypia or whatever, whether or not you have villi, it doesn't matter. I mean, the fact of the matter is that the treatment is going to be virtually identical. Whether or not the risk of metastasis is different or not, I don't have enough experience on that side to know in our current paradigms whether there's really enough evidence to say that a pure choriocarcinoma has a higher metastatic potential than an invasive mole. I would suspect it probably does, just in terms of thinking of how the continuum goes.
So the old literature I know has, and this was the...
Okay, what actually...
Go ahead, Dr. Okekwe, please.
Okay. I wanted to say, I know that most times, if you see villi, you can't call it a choriocarcinoma. But I want to find out if, since you, in your climb, you're able to see cases early, I don't know whether you have come across any case, because you are talking about having a case where you can have choriocarcinoma and you're able to see some villi. Are there cases like that? I just want to know.
Yes.
In your experience?
So that is the discussion that we're having. So for the first time, WHO 2020 came in with with a comment, not specifically designating an entity, but saying that some molar gestations have exuberant trophoblastic hyperplasia, and those probably represent intramolar choriocarcinoma. But it was just a comment. There's not a huge amount. It's a concept rather than a diagnosis at the moment. That's what I would say. There are people who think that that might be true. I am disinclined. I think that when you see villi, we probably should not be diagnosing choriocarcinoma unless you see a clearly defined nodule that is invading like a choriocarcinoma without villi. There's a paper.
Like this area right here, right?
Nope, I still see a villus up there.
Yeah, there is a villus, but then I mean, if you took a picture of this bottom half and put it on a board exam, people would say, "Oh, that's choriocarcinoma," and here's the invasive
so
component.
I think so that's what so Biggie Ronette has a paper from a few years ago, and it's maybe 7 or 8 choriocarcinomas. Some of them are post-molar, some of them are post-normal gestation. And she basically says that they weren't, they were these moles with exuberant proliferation, but even the areas that they thought could be choriocarcinomas, in 60% of them, when they did deeper recuts, that trophoblastic area, they found villi. So they did not, they discuss it as, it sounds reasonable that choriocarcinoma was arising in the mole, but I don't think that the diagnostic criteria have been refined. And so from my perspective, if there are villi, it's a molar gestation. What I would probably do is write a note saying that there is exuberant trophoblastic hyperplasia. But even that has no weight because the WHO algorithm assigns a score for the level of HCG. So if you've got huge amount of trophoblastic hyperplasia, the patient's HCG is going to be over 100,000, and that's 4 points straight off the bat that the patient gets. And 6 points puts you in high risk. So I'm not sure that I think it's maybe conceptual or hypothetical argument. And I think for molar gestation, it becomes really difficult because when you think of epithelial proliferations or even melanoma, there's an in situ lesion. And the in situ lesion actually does not behave like the invasive lesion. It behaves more like benign. And so to me, it seems like if we were to call this choriocarcinoma, you would have to define something that is in situ choriocarcinoma. and so then we're just like, the concept does not appeal to me. I've said too much already there, especially since the concept is proposed by my colleague.
We had actually many cases of relatively many cases of both non-invasive and invasive molar gestational trophoblastic disease recently. Yeah. And we saw areas of extensive trophoblastic proliferation, which was frightening enough to consider choriocarcinoma with areas of necrosis. Yeah.
Okay.
With areas of necrosis and hemorrhage. But with, as you have mentioned, with deeper cuts, if you could find like a single chorionic villi also, we will just call it molar pregnancy, not a choriocarcinoma. We had like a series of cases, like recently even 5 or 6 cases, which was discussed in this slide session.
So I'm going to throw out an idea there. Maybe Zuditu, Dr. Okekwe, you might want to collaborate. So because this is a disease that we don't see very much in this country. And so it would really be helpful to get, you could easily write a small paper. I'm sure the International Journal of GYN Pathology would be interested in accepting it because yours is the setting in which you will be able to define the amount of trophoblastic hyperplasia. Most of the molar gestations that I see are less than 9 weeks. So I don't see a huge amount of trophoblastic hyperplasia. So you could actually help us here and get a paper out of it. So if anybody is interested, I'm happy to help you put that together.
Okay, thank you.
Okay.
All right.
Okay, thank you.
Very good discussion, very interesting questions, and thanks for indulging our conversation.
Yeah, this was really good. Thank you, both of you. I think we're up on time, so we're going to end here. I think our next meeting is officially our last meeting. And perhaps Lewis and I can discuss offline. I don't know if you guys are interested in continuing sort of pathology tumor boards. Maybe we won't do them as frequently as we do them now. But I've certainly enjoyed the experience. I found it educational. It's helpful. We're hoping to expand our gynecological pathology sort of fellowship offering. And we hope that you guys will continue to engage with us.
Hello,
And you
could
can
you
help
come
become
back
mentors
a
for
little bit?
others.
I didn't hear your last comment.
So we're hoping, so last month, I'm sorry, December is our last month for this group, for this type of session. So one, if you could let us know if you would like to continue, we probably wouldn't continue at the same frequency, but we also want to remain connected to you and be available to help you in any way that you can. We also encourage you to think about continuing because we're hoping to expand, and we hope that you will become mentors in the next iteration of our program. So we would like to stay connected so that you can join the movement, shall we say.
Sure, we are in.
Yes.
Okay,
Good.
all right.
Well,
Yes,
thanks,
thank you.
everyone.
Thank you.
Thank
Thank you.
you.
Bye.
Thank you. Bye.